Regarding the clinical prediction rules, an important thing when people come to our clinic is that they always ask, okay, this is good for me, how long it's going to last, a lot of questions, so sometimes you can imagine that some muscles, some patients are going to react differently. So regarding the type of muscles, usually when we apply dry needling in upper limb muscles, we have a very fast effect and the patient is not being very sensitized, so changes in the function are very clear. But when we move to the lower limb, some muscles like soleus, gastrocnemius, I think you can imagine, get a bit sensitized, so in the 24 first hours perhaps the movement is not so fluent, so good, but after 24 hours it improves. So this was a study that we recently submitted to a journal about the tensiomyography. So a good point here was it was just one case, and we wanted to measure after dry needling, which was the measurement of the contractile property. So this machine gives an impulse, a current, and it measures the displacement of the muscle fibers. So this dm parameter is the displacement. So an interesting thing is that for some muscles we had a direct effect just post-treatment, but for example, if you have a look to gastrocnemius lateralis, the displacement of the muscle didn't increase. So if I have a spastic muscle, a very contracted muscle, the displacement will be very low. If I do dry needling and it relaxes, the displacement will increase. So all the muscles increase, but for example, gastrocnemius lateralis didn't increase. So this correlates with some of the clinics saying that after dry needling, the patient is like sensitized, is stiff, so there is no effect, or there is a bad effect when we do dry needling. But if we make the follow-up, we realize that some of them continue improving and some of them not. So for me, for example, in this gastrocnemius, they improved after the treatment, at least for the displacement of the muscle. So this made me think that not all the muscles are behaving in the same way, as you know that in trigger points, not all the muscles behave in the same way regarding the referred pattern of pain, the possibilities to give referred pain and all these things. So this was just a picture trying to correlate with the clinical information. Regarding the precision and safety, perhaps if there is some problem, because when we do a lot of force to put the needle into the muscle, we have to remember that neuropatient has a lot of remodeling tissue. Sometimes it's very difficult to say if we have had reached this trigger point. So as you see in some studies, perhaps a good option would be to record if there are any existing local twitch responses. For me this is very important, like in the study that Lynn was presenting, and you did some of the questions very interesting for me, is that when we apply a drug when we give drugs to the patient, antispastic medication, the dosage is very clear. You have to take one pill every 8 hours. But when we do dry needling, when I read papers, they say we apply dry needling. We say we did entries, but my concern is, okay, and which was the dosage? So you did 20 entries, you did 20 entries with one local twitch response, or 20 entries with 20 local twitch responses. So I think that in the future research we should consider this as a second variable, because perhaps the way of improving or not, or the way they sensitize more or less, would be depending on this secondary variable. So for me, in my mind, this should be considering future studies. So we try to say, okay, this is a second variable, but how many entries we are doing, how many local twitch responses we are feeling, because we have to know that we are not going to feel 100% of the local twitch responses. Even if we use an ultrasound, it's possible that if the tissue is very hard, we can really say we have had this exact amount of local twitch responses, but at least it will be better than not making the effort to count or to register all these things. So I would like to transmit this opinion to you, because I think that it can be useful for the future. So, apart of that, we are not injecting anything. So, we have to palpate very well, we have to be in the good target, and we have to try to be very specific. So, we cannot be doing this. So, just dry needling all the muscles at any side. So, I always do some jokes about that, but this is the real thing. You have to do the less amount of punctures, but they have to be effective, okay? And the last thing is the comparison with botulinum toxin A. So from a legal point of view, in some countries we can inject, so it's a good option for physical therapists. We haven't had any adverse effect, and as Clina was saying with the manual therapy, there can be some adverse effects, but if the techniques are bad done and the frequency is very low comparing with other techniques, it's cheaper. We don't use money. The needles are really cheap. The toxin is much more expensive. We have a better clinical integration because we can be doing active movement, we can be working with the patient, and we can dedicate just 5 minutes to do dry needling and continue working, because this allows a better integration in the clinical setting than the toxin. There is no a risk of exceeding a dosage like in botulinum toxin. So, for example, for children that they can stand a high dosage, this could be not an alternative sometimes, but this could be a complement even for some patients that can receive more botulinum toxin infiltration. And regarding the effectiveness, we are trying to develop clinical trials, although we are now trying to demonstrate it's effective so that they allow us to compare with botulinum toxin. So I'm afraid it will be a long time until we publish this, but at least I think we are in the way. So you can be updated through all this website where you can find videos, you can see different things. And I would like to give you some take-home messages. So I think that as a summary we can say that dry needling can be an important complement and perhaps in the future even an alternative for the treatment of pediatric neurological patients due to its structural effects and the ability to neuromodulate some issues in the central nervous system. But on the other hand, high quality training is necessary and professionals must work with rigor. So I know that all of you have a very good training, but when you move through the wall, you really see some disappointing things. And I think you have had the experience sometimes to see videos in internet, but sometimes you say, no, this is not dry needling, I don't know exactly what is this. But you will never have effect if you do this, because this is not the same thing I'm speaking about dry needling. And the last thing is that this could be an alternative to the botulinum toxin infiltration because of absence of secondary effects and because there is non-existence of limits regarding the dosage up to date. So on behalf of San Jorge University and on my own behalf, this image represents my life. Thanks very much for your attention and the opportunity to be here.